Firstly, I wanted to reassure the panel of staff's absolute commitment to provide the very best emergency care services and urgent care services in this part of the world, both from the South West Acute Hospital in Enniskillen and indeed from the Tyrone County Hospital here in Omagh. As you'll have heard in previous presentations, particularly in the Verbal Arts Centre earlier on, even though the performance of the emergency care services in this southern sector of the Western Trust are the best in Northern Ireland and have been over a considerable period of time, we are not at all complacent about our performance, and we recognise that there's always opportunities for improvement, and indeed hearing some of the testimonies today just reinforce that for me. Doctors, nurses and support staff and managers working in both departments are constantly reviewing their practices and constantly reviewing the feedback from service users, of which we get quite a lot from various forums. So we're constantly trying to seek out opportunities to improve the services even further. As you'll be aware from some of the information that you've received in advance in terms of the submissions, the emergency department has consistently achieved in the region of 95% performance in relation to the 4-hour waits, and it is some considerable time since we've encountered a 12-hour breach, unlike lots of other places. I think it's important really to give you a bit of the context and to explain that, first of all, the South West Acute Hospital is classified as a Type 1 unit, treating approximately 30,000 patients per year. The Urgent Care and Treatment Centre based here in Omagh in the Tyrone County Hospital operates as a networked minor injuries unit, which deals with approximately 17,500 patients per year. The South West Hospital opened as a new acute hospital for the South West in June 2012, and it represented at that point in time an investment in the facilities of around £276 million on a greenfield site. It provides the very best environments for patient care and utilises state-of-the-art equipment in the delivery of those services across all the specialties, including the emergency department. So issues around privacy and dignity and confidentiality have been built into the design of the hospital from the very start to ensure that patients are cared for appropriately. So, for example, the South West Acute Hospital, all of the patient rooms are single rooms with ensuite facilities. All of the patient single rooms have access to patient information system, so that in ward rounds and other interactions with the patients by our staff, it's done in the confidentiality of that patient's bedroom. And they can, of course, choose to have their family members present during those consultations. The Tyrone County Hospital is scheduled for replacement in 2016. It's currently being built on the Tyrone and Fermanagh Hospital site here, just on the outskirts of town, at a cost of £105 million. It too will have single room ensuite facilities as well. And the Urgent Care and Treatment Centre will also be co-located with the cardiac assessment unit and the treatment room services of local GP services as well. So we're building in that adjacency issue in terms of the natural flow of the patient pathways into that design of that building. So following commission, we expect to have the new hospital fully operational by October 2016. The design of both hospitals has been driven by active involvement from all key user groups. So we have used all of the user groups that my colleague, Equality and Human Rights officers referred to earlier in the design of the hospitals. So issues around adjacencies, wayfinding, signage, technologies have all been informed and tested by those user groups who have represented all of the user groups that we're familiar with, including age-specific user groups, children, older people, and all of the groups with particular special needs and or disabilities. In February 2009, acute services in the southern sector of the Western Trust were reconfigured, and you'll have heard this referred to earlier on, with the result that all acute services in the southern sector of the Trust were transferred to the former Erin Hospital in Enniskillen, now the South West Acute Hospital. And not surprisingly, at the time of reconfiguration, there was a lot of concern within the local community here in Omagh, and the local Omagh community quite rightly sought reassurance that services would be responsive and meet the needs of the local population. So at that time, we invested considerable effort in work which was undertaken in developing a range of specific patient pathways for various conditions. For example, people presenting in emergency departments or urgent care and treatment centres with a variety of surgical conditions, medical conditions, trauma, fractures, paediatrics, ENT, chest pain, cardiology, abdominal pains, neck and back pains, falls, deliberate self-harm, overdose, intoxication. So for each one of those categories, we developed specific patient pathways so that everyone was clear, not only within the hospital setting, both in the urgent care and treatment unit, but also in the emergency department, and equally importantly in the local community, what those pathways were. All of those pathways were signed off by multidisciplinary teams, incorporating all the specialties and also the Northern Ireland Ambulance Service. And we've since, within the last 12 months, reviewed all of those patient pathways, and we've tried to create a bit of flexibility where it has been appropriate to do so, to ensure that where appropriate, more patients are treated in the urgent care and treatment centre rather than having to attend a type 1 emergency department. In addition to the establishment of the urgent care and treatment centre in Tyrone County Hospital here in Omagh, the Trust also in 2009 invested a significant additional resources in enhancing locally based cardiology services. Because this is one of the great concerns from the local community. What would happen if one of my family collapsed in the street and they're 25 miles to the local South West Acute Hospital? So what we developed at that point in time, and it's still in place, is a cardiac assessment unit, a 4-bedded cardiac assessment unit, a cardiac investigations unit, a rapid access chest pain service, and consultant-led outpatient appointments led by consultant cardiologists. This service has been so successful that I wish we could charge for the number of visits we've had from all over the UK to see how it works. So for example, in the month just completed in September, the cardiac assessment unit dealt with 283 admissions here in Omagh, 236 of which, after investigation and treatment, the patients were able to be safely discharged home with further follow-up work as appropriate. On both hospital sites, we have co-located GP out-of-hours services, and that helps create a seamless service between primary care and the emergency and urgent care service. Despite the fact that staffing levels fall short on the recommendations from the College of Emergency Medicine, and you'll have heard this earlier on in presentations, that the College of Emergency Medicine recommends that for all type 1 emergency departments there should be a consultant complement of at least 10 consultants. And in the South West Acute Hospital we have 3 consultants and 1 associate specialist. And similarly within recognised nurse workforce modelling, we're also well below the recommended levels. But despite that fact, the emergency department in the South West Acute Hospital works as a whole hospital system. And in that I mean that physicians and surgeons across the hospital are actively involved with emergency medicine consultants in terms of the in-reach into the department and the patient pathway through the entire hospital into the right specialties. Also within the South West Acute Hospital, we have, I believe it's the only one in Northern Ireland, we have a combined medical and surgical assessment unit. Quite often these are standalone, separate units. But in the South West Acute Hospital, we have the commitment from both specialties to work together as part of the assessment team. The medical and surgical assessment
you're
unit...
in your last minute, if I may.
I'm nearly there. The medical and surgical assessment unit delivers an efficient pathway of care for patients that ensures high quality assessment, early intervention and treatment, and a decision to either admit or discharge. The average length of stay for patients being admitted into the medical and surgical assessment unit is 16 hours, and 35% of the people who are admitted are assessed, treated and discharged on the same day. And 35% of the patients who are coming into the hospital setting as emergency admissions are direct referrals from GP practices. So again, we're not double counting in terms of them coming through the emergency department and then being referred on to the medical and surgical assessment unit. Where it's appropriate, it's a direct admission. Finally, as part of our commitment to ongoing involvement, we actively review all user suggestions, complaints, incident reporting, and mortality and morbidity reviews are part and parcel of what's done in each department on a regular basis. We have a group of 80 volunteers working across the South West Acute Hospital of all ages, and I'm pleased to say we also have a number of our clients from various institutions in the locality working as volunteers across the hospital as well. As part of our learning culture, we particularly welcome the efforts of this panel to inform how we can further improve our services, and we're determined to do that.
Joe, thank you very much. I would ask two or three questions. The first one I think you may have answered in your 5 minutes, but you might want to elaborate a little bit more, which is, in a sense, we're not comparing like with like in terms of hospitals. Different hospitals have obviously difference in size and scale and how new they are in planning terms, but it's clear that the South West Hospital does do so much better in terms of the key objectives that are set by the department, about 4 and 12 hours. And I wonder what lessons you think that has for other trusts who are struggling to meet the kind of targets that and outcomes that you're currently meeting on.
Well, I think you're absolutely right. It's a case of not one size fits all in relation to this. It depends on the patient mix and the throughput and all of the rest. But some of the things that have worked to our advantage in the South West Acute Hospital is the fact that we've been able to design the emergency department in the right part of the hospital with the right adjacencies. So right beside the emergency department, we have the radiology department. So we have CT, MRI, ultrasound right next door. So you haven't got a situation where patients are traversing the entire hospitals to get to the right locations and get the right investigations done. And directly above the emergency department is the cardiac assessment unit, the cardiac investigations unit, and right beside that is the surgical side of the house and intensive care and high dependency. And directly across the corridor is the medical and surgical assessment unit. So the fact that those co-locations are correct certainly helps the flow of patients. Undoubtedly, the combined medical and surgical assessment unit works extremely well and works extremely well with the emergency department. And it is of a scale where we don't have a very elaborate middle grade medical structure in the hospital. For example, we have no registrars on staff across any of the specialties. And that forces each of the specialties to have to work very closely together to make sure that the whole system works. And in some hospitals where they are of a size where the specialties are so big, they're almost like separate institutions within the overall system. and it proves much more difficult to work together. The South West Acute Hospital doesn't have that. And I don't know whether, Dr. Brown, you want to add anything?
Yeah,
to that?
no, absolutely. And I mean, we have been performing consistently well for a while now, and we have sat down as a group on a number of occasions and have asked ourselves, how are we continuing to achieve this? And I think probably, as Joe said, the two probably key things that have come out of it is the fact that physically we're a big hospital, but as a functioning unit, we're still quite a small hospital. And we work extremely closely with our colleagues in the medical, the surgical and the paediatric units, to the point where we can lift the phone at any time of the day, speak directly to the consultant who's on call. That particular consultant will quite often come down to the emergency department, will see the patients themselves, make decisions on admission and discharge. If you come into our hospital any day of the week at 10 o'clock at night, you will probably bump into the consultant surgeon or consultant physician who's on that particular day, who will actually be physically on the floor in the emergency department overseeing their junior staff. Something that having worked in a lot of departments around the country, just doesn't happen. And I think it's because, as Joe said, those other specialties are such sort of big units, and quite often they have their own agenda, whereas in South West Acute we all seem to work for a single agenda, and that's basically working for what's best for the patient. And the other thing, as we'd also established, was that having the assessment unit, the combined medical and surgical assessment unit, we have a flow of patients. The majority of our GP, probably over 80% of referrals from the GP, come directly to the assessment unit. And if you like, cutting out, if we can call ourselves the middleman, where you have a qualified GP, he's assessed the patient, he's made a decision, and rather than send them to ourselves to be assessed again, for us to quite often make the same decision and then pass on to a medical or surgical team, patients can bypass us and go straight to the assessment unit. And by doing that, it reduces the number of people that are coming through our doors, and then allows both our medical and our nursing staff to concentrate primarily on what we would call our own emergency department patients. And it means then that the flow tends to be better. We don't have issues with crowding. It keeps our waiting times down. Even, for instance, the ambulance service, probably about 90 to 95% of patients that arrive by ambulance will be taken off the ambulance trolley and put into a cubicle within 5 to 10 minutes. There is days when we're busier and that may go up to 15-20 minutes, but we don't have a situation where people are on ambulance trolleys for hours waiting just to be offloaded into a cubicle. So I think those are the two key areas that seem to have make our performance consistently, as Joe says, the best in the province for quite a while now.
And I suppose the other thing just I wanted to add was that, and I can see this right across the Trust, we've tried for all the right reasons to make sure that we have a good dialogue with our GP colleagues, just to make sure that what we're doing adds value to what they do and is in the interests of patients. And in the southern sector of the Trust, we have a very, very active and committed GP group whom we meet with 3 or 4 times a year. The hospital, the South West Acute Hospital and Omagh meet with them, and we go through all of the specialties with them in terms of take them through any particular innovations or changes or problems and so on. And it's a real good dialogue between GPs and the Trust that I have seen in 3 or 4 years, real improvements that have been made to unblocking blockages in the system. And despite our best endeavours in the northern sector of the Trust, we've never been able to get the same engagement. And we're left thinking that, it's in the southern sector of the Trust, it is a rural community. and GPs have all the same issues that you would have in a rural community. When we're trying to do it in the northern sector of the Trust, we're trying to do it with Northern Ireland's second city and a rural community as well, and there just isn't the gelling that there is in this part of the world, and it works extremely well in this part of the world.
And just maybe to add slightly to that, we have a particular agreement, and it's something that we come up with ourselves with the local GPs, that they can at any time phone through and speak to us directly. So they phone through to our switchboard, and if they identify themselves as a GP, they will be put through directly to speak to one of us 3 consultants that are on call that day. And again, I know in a lot of places the GPs don't have that direct access to sort of specialist advice, but we felt that this was important because it meant that we could advise the GPs on where best to place the patient, even to give them advice on treatment, to decide do they actually need to send the patient to hospital or not. And I think the GPs appreciate the fact that they can phone through and they're speaking to somebody senior, and that's 24 hours a day. They can do that with us. So and I think that again that's a big help towards getting sort of the right patient to the right place, at the right time, and it works very well with our local GPs.
2 other quick questions from me then. One is, we'd heard earlier, I think, in evidence from the Northern Ireland Ambulance Service about the development of protocols, and if I've got this right, the one place they have a protocol at the moment is with the Western Trust. I'm not sure if it's both across the southern and the northern part, which is that a considerable amount of initial kind of diagnosis and possibly care might be done when the ambulance arrives at the person's home or en route, in order again to try and see actually whether emergency department is the right place to go. Have I picked that up right, and have you got those protocols? And just your impression of how that's working in practice.
Yes. Well, certainly we work very closely with the ambulance service, and I particularly, in my time off, I'm what's called a basics doctor, so I carry a pager and a radio for the ambulance service, and I actually go out and respond for them as a volunteer to serious incidents around the community. So I work very closely with the ambulance service, so they have a sort of almost quite a sort of unique bond with ourselves. And again, like the GPs, the ambulance service can phone in at any time and ask for advice, and do on a regular basis. And again, a system like that at the end of the day can only benefit the patient, because we can often advise them on possibly an alternative route to take other than coming to the emergency department, or we can advise them on the initial treatment. And of course, obviously, if they need to come, we'll advise them to bring them to ourselves, and we'll treat them. And one of the other areas that I was largely involved in was, as Joe had mentioned, was putting together a lot of what we call destination protocols for the ambulance service, and this involved quite a lot of work, both for the ambulance service and for sort of the local community around Omagh, because we didn't want people in Omagh to feel that the urgent care centre was purely for cuts and bruises and nothing else, because our EMP service there are actually very, very qualified, experienced nurses who actually deal with a lot of injuries and a lot of minor illnesses as well. And we wanted people in Omagh to realise that they didn't always have to come down to Enniskillen, and they could actually have a service on their doorstep that quite often would serve their need. So we put together a lot of protocols with a lot of conditions that people probably didn't realise could be treated in the urgent care centre. So the ambulance service would then be able to realise, well, they could start bringing a lot more patients to Omagh instead of bypassing and coming to ourselves. And again, the staff in Omagh were quite clear as to the types of conditions that they would accept and treat. And we're due to revisit this again in the next few months, but so far that seems to be working very, very well.
So for example, if I could give you an example, one of the things that we've changed successfully is initially the Royal College of Psychiatrists had a very definitive position in terms of people who presented with an underlying mental health problem but also intoxicated, that they would only be subject to an assessment process whenever their levels reached a certain level. And what we found in the early days of the transfer of acute hospital services was that there was an inordinate number of people who were being transferred out of the Omagh area to the South West Acute Hospital, only to get their levels down and then to be assessed. And what we agreed through the Royal College of Psychiatrists and our local psychiatrists was a tolerance in terms of keeping those people in Omagh at a higher level, but safely, so that we avoided that unnecessary transport to the acute hospital and then back again, because our local mental health hospital inpatient facility is here in Omagh. So things like that we've looked at, and we've looked at it creatively but appropriately in terms of modifying those destination protocols and patient pathways where it makes sense to do so.
Okay. So one of the ones in my head, and Joe, I know you were here earlier, I don't know whether you'd be able to answer this, and it might be one for the nursing. One of the bits of evidence we had was at the minor injury unit in Dungannon that it was what did prove to be possible to do what looked like relatively minor sort of catheter issues for people with an internal catheter who were presenting then with difficulties, who were either having to go to the emergency department or perhaps back to their GP. Now, I wasn't sure whether that was a particular issue for that particular minor injury unit, but in terms of Omagh, for example, if you had presented with a problem with your catheter and you needed a nurse or somebody to, could that have been done on site in Omagh, unlike what we heard in Dungannon? Or
I think some of the other services that can be utilised from Omagh are not only emergency departments, but rapid response teams in the community, which are nursing teams who are highly trained in taking on areas such as catheter care. So they're therefore treated in their own home by these particular nursing staff. And obviously, if it's outside their own competence and abilities, they're then referred into hospital. But the initial stage of them, that particular type of patient would be utilising rapid response teams.
So the Urgent Care and Treatment Centre in Omagh does deal with catheters?
Mm-hmm. So you would have been at least able to assess,
yes,
this is something beyond our competence, or no, it isn't, and we could...
And in fact, as part of our governance for the Urgent Care Centre, we do a clinic once a week where the EMPs will bring back patients where they want a medical review on. And so we go up and spend a Wednesday afternoon in the county, and just 2 weeks ago I was doing that clinic. And while I was there was a patient who got a catheter change done while I was there, because if it's a simple change of catheter, the majority of the nursing staff there are capable and are willing to do that. If it's something more complex, then they will refer that on, but they can do it.
Okay, and this is a final question for me, and this is really, I guess, to both Ronnie and Campbell. We've heard quite a lot of evidence which is in direct conflict from one another around the notion of whether there is a bullying culture within emergency departments in terms of, and we know that from the RQIA that was an issue in report, there was an issue in Belfast. So we've heard, for example, from the Royal College of Nursing, who've said, yes, it is a problem, worse in some hospitals than others, but it's there. We've heard from Unison, for example, that it's endemic across hospitals. We've heard from the BMA, who said there's room for improvement. On the other hand, when we've talked to trusts, really what we've heard is that that's not, either it's not an issue at all, or at most, yes, these are stressful places to work, and occasionally things happen that probably shouldn't, but that's not a culture, and it's a difficult workplace, and you work under stress, etc., etc. And those two things clearly don't marry, again, the experience, if you like, from those at one end of the shop floor from those at the other end in terms of management. So I suppose it's a question to both of you. What's the position in terms of the southern area of the trust from your point of view as managers on the ground? And do you have, if your view is very much with the other trusts, do you have any sense of why there is such a disconnect between what those who represent staff are saying and what those on management side are saying?
I suppose, obviously, we're all aware that the staff work within such a challenging environment, and that varies from day to day. But being the manager of the emergency department, and you know, we've always promoted an open culture within the department. Staff, I believe, have you know, full access to both myself and medical staff with regards to any operational issues on the floor. We know certainly we have the operational targets to meet and other standards to meet, but you know, there's no denying that we do work within a challenging environment. But as I say, we meet on regular basis with staff on the shop floor through bi-monthly departmental meetings, through improvement group meetings, and this gives staff an opportunity to voice any of their particular concerns to the likes of myself and Campbell around a table in a very open environment, and that goes to all staff from senior nursing staff right down to the more junior staff.
And I think, you know, if you go back quite a few years, and I can speak from experience, going back to sort of the early days, and if you look at medical and if you look at nursing and management, there was certainly in my day almost a tradition where senior medical staff would have been, if you like, tough on the junior staff. And you'd have seen examples of that within nursing, where senior nursing would have been quite strict, if you like, with their more sort of junior staff. And there was very little engagement with management at all. So there may well have been that a certain amount of that culture, but I think things have changed quite dramatically over the years now. And I'm not saying that there probably isn't a degree of that behaviour goes on, but I think certainly it's probably changed dramatically from what it was going back over the years. And as Ronnie says, that, you know, staff will come to us. We have a very open department, very much an open door, where we physically, if we're in our office, we will keep our door open so staff can come in at any time and speak to us. And they will come to us, and they will on occasions bring up different issues. But I have to say, honestly, that that wouldn't be an area that people would speak to me about very often, if ever, really. Certainly in my 3 years there, I don't think anybody's actually come to me with a problem, you know, along those lines.
And if I can say to you, give you a perspective on this, I live above the shop 2 or 3 days a week. Saves me travelling up and down. And I don't sleep terribly well either when I'm away from home. So I'm quite often poking around, and quite often would be in and out of the emergency department at different hours of the day and night on various, just having a look to see how things are and so on. And it is very much that open door policy culture. And you'll have heard this from Elaine Way in her presentation to you as well. And it does work in practice. However, I would have to say to you, and it's been enlightening for me to see it firsthand. I still cannot believe the abuse that staff in particularly emergency departments take from some members of the public. It is absolutely appalling what they have to take on occasions. And I'm astounded by the number of occasions where the police will be called to the department to control abusive patients. And if you were following the local press here this week, there have been 3 cases up, both in the courts in Derry and Omagh and Enniskillen, of patients being taken to court because of their violent behaviour to members of staff. Now, we expect staff to do that and to deal with each of those patients professionally, and when the next patient comes along, to really forget about that and carry on professionally as well. But it is a really, really challenging environment, and I think sometimes people forget it, that haven't the experience of it. And it is really, when you see it happening in front of you, it really does paint an entirely different picture. But what we've tried to do in the Western Trust, and I think successfully, and I think that's what Campbell's referring to and Ronnie, is we've tried to create a culture of an open door policy for all staff. and it does work.
Yeah. I mean,
And one of the problems that you'll have heard fed back to you through the RQIA report was a feeling of a disconnect between the front line and senior management across the organisation. I don't think that's the case in our organisation, to be quite honest.
Mm-hmm. I mean, as Joe said, obviously Joe's part of our senior management, and you know, when you speak to medical and nursing staff, you'll always hear stories of them and us, management and clinical staff. But I have to be honest and say it's not like that in South West Acute. And I mean, you'll find no other hospital where the chief executive will wander through your department a couple of times a day, most days of the week, and sometimes you have to actually throw them out. You just won't see that in other places. But we are actually privileged that we can do that, and we can engage with Joe and some of our other directors face to face any day of the week, without any kind of hostilities. And what it has shown, certainly in the last year, we've had a couple of quite sort of high-level meetings, is that by meeting face-to-face, we're getting things done, decisions are being made, things are being actioned, and we're moving the system forward, and it's great to see that.
Okay, Marion.
Just a few questions. One of them, you've described the system where you have GPs co-located, where you have GPs having 24/7 access to any consultants, where you have round about a third of your patients directly admitted towards by GPs. Why can't that system work in other hospitals? Is it only something that can work in small rural communities?
Well, no, I think the reality is it could work, but I think the emergency department and the GPs obviously need to get together and to make it work. I mean, we're a good example of how that system does work, and other hospitals have asked us how we do it, but I don't think it's a difficult process, but it's getting the different groups of people, and it was not just the GPs in the emergency department, but it's also getting the physicians and the surgeons together and sitting down and deciding, this is what's best for the patient, this is what we're going to do, and let's make it work. And I think the answer to the question is it could work, and I don't know why they don't use that system elsewhere.
Well, I do think in part, Marianne, it's a scale problem in some hospitals, and in the Southwest it works because the direct referrals in the main, for the vast majority of that 35% that come in through the door, go into the medical and surgical assessment unit, where they're assessed properly by the surgical side of the house and the physician side of the house. It's not that they're going directly into the wards. And for example, that had been happening in Altnagalvan, and it was unmanageable, because what you were finding was that the wards then were completely chaotic in terms of the number of admissions, and the people were backed up in the emergency department as well. So the Southwest works, I believe, because of the effectiveness of the combined medical and surgical assessment unit, primarily, and also because of the dialogue between the senior consultants and the GPs. So that if there is a problem, they can speak to somebody and get that problem resolved.
I think too, another issue that certainly that I've heard over the years, again from different departments, is that a lot of departments obviously like to keep the numbers of patients coming through their departments high, to almost, if you like, to justify their existence. But of course you're doing that at the detriment of the care that you're giving then to your patients. And we are a small department, but we certainly believe that the current system we have, where a significant number of patients are bypassing us, is the best system for the patient.
Mm-hmm. Can I turn to locum staff? And one of the things that Joe, you said was you're in nursing and in consultants, and I think in middle grade staff as well.
Absolutely.
Southwestern staff are well below what the is the recommended level. Now you have managed to deal with that by bringing consultants from other specialties in, from what I've said, they come to the emergency department and see and assess. Is that right?
Well, no. What we have a group of locums who work for us basically full time on our.
No, but I'm going to go on to the locum shortly. I'm just talking about to bridge your deficit.
No,
It's not bridging the
no,
deficit.
no.
It's ensuring that the patient pathway is as streamlined as it possibly can.
Mm-hmm.
So if the emergency, if the consultant in emergency medicine requires the advice of a consultant physician or a consultant surgeon, then they will reach into the department.
Mm-hmm.
They'll come down, they'll see the patients there, and they'll deal with them that way.
And would that happen in, say, the Omagh or the RVH, or is that?
Not as slick as that,
So
and not
it's-
as
it's
regularly as
typical-
that.
Typical of your situation. In terms of the locums, what impact does the employment of locums have on your budget? And also, what is the likely impact on your ability to train medics in particular, and to continue to have training recognition from the college?
Well, maybe if Campbell picks up the operational issue, I'll pick up the budget issue for you. Across the Western Trust, we spend we'll spend this year £7 million on medical locums. And there is a premium on average that you will pay, which is a third more than you would pay for an NHS member of staff. And that's the premium you pay for it. And we have consistently made the case, because it's always been the same in the west of Northern Ireland, that when you're on the periphery of Northern Ireland, it is really, really difficult to attract and retain staff. And particularly when staff in the main are coming through Queen's University in Belfast, by the time they come out of training, they have their family networks and their friendship networks and everything established in and around the greater Belfast area. There is a reluctance then to up sticks for they and their partners or family members and move to the west. And it's the same for Altnagalvin as well. However, I would say to you, and I'm constantly reassuring local councillors in the local community, we have a consultant complement for the South West Acute Hospital of about 70 consultant grades. Historically, we would always have had a vacancy factor. But from the day and hour that we started to build a new acute hospital, I sit in all the consultant panels, both the numbers of candidates coming forward and the cadre of the candidates coming forward increased significantly. And it was just, we reckon it was a vote of confidence in acute services in the West, and it was here to stay, and therefore people were prepared to commit to it. So currently we have, out of the complement of consultants, we have 3 vacancies in the South West at this point in time, which is really, really good. Where we struggle is the middle grade doctors across all specialties, and I'll let maybe Campbell speak to that.
Yeah, unfortunately we have a big reliance on locum medical staff. Our senior medical staff of 3 consultants and associate specialists are permanent, but below that we have 1 GP trainee that we get every 6 months from NIMTDA, and we have no other trainees. And if you sort of put it into perspective, there's currently 101 trainees in emergency medicine in the province. We have 1 of them. Unfortunately, the bigger hospitals like Belfast and in the Northern and South Eastern Trust tend to get the majority of the trainees, and we've approached NIMTDA on this subject. And well, there's 2 issues. There is a national shortage of trainees in emergency medicine because, unfortunately, due to the high pressures of the job and the amount of sort of antisocial hours, it's not the most attractive specialty. So there is a general shortage of trainees going into the specialty, and because of that, the trainees that are coming out are being allocated to the bigger hospitals, and we have been told that certainly for the foreseeable future, we have no real chance of getting any of those trainees. So we're then in a position where we have to then rely on permanent non-training staff. Now, a number of years back, there was a lot of people out there that we could have attracted to the job. But when the whole training system changed a number of years back, all those people got, if you like, mopped up into these sort of fast training schemes and all the different specialties and general practice. So there's no longer that cohort of people out there that we can try and attract to the specialty. And we're in a position now where we rely below our senior tier. We rely mostly on locums. Now we are in a good position in that the locums that we do have, we have had them for quite a long time, so they're well established. They work full-time hours for us. They're quite experienced, and in fact, if you were to look at the experience of our complete medical staff and within the emergency department, it's probably on a higher level than any other department in the country, purely because we have experienced staff that have stayed with us over a long period of time. But it's not an ideal situation because we don't know really from month to month if those staff are they're not under any contract, so they can leave at any time. So we don't have that security of a regular workforce. And certainly when it comes to the training point of view, we will train our locum staff as best we can, and we do actually, at the expense of the trust, engage our locum staff in a lot of the in-house training, purely because we look on it as a good investment, whereas other establishments will not train their locum staff because they're not paying for them essentially. So we've actually put together, one of my colleagues has just put together quite an extensive workforce paper, which is being presented to our senior management team in November, looking at both our medical and our nursing staff, and we've put into that a lot of solutions, a lot of ideas of how we can try and overcome the issues that we have, and we're hoping, fingers crossed, that we'll be able to push this through our corporate management and on to the commissioner, and possibly get some funding to try and solve some of the issues that we currently have at the minute.
So historically we would have been able to rely on very well trained and skilled people from India and Asia, and as you know, as part of the European Union, we're no longer able to do that. However, we are making a case currently to say, look, we have exhausted Europe and we're still sitting with a vacancy factor of over 30% in our middle grades right across the trust, across all specialties, and we really need permission to go beyond Europe to try and attract people to fill these posts.
I'm running out of time. I've probably gone over time.
Yeah.
But I have one more question, but if you want, I'll sacrifice it.
Well, ask it, but maybe a very quick answer to it, because I am conscious of time. We are, and I want to let Paul have his share of time as well.
Show, so maybe doing this.
So a quick answer to a quick question.
Okay.
It's just really in terms of the emergency department journey for particular vulnerable groups such as elderly with dementia, mentally ill patients or children, and what's your take on how well that journey is operating for those groups, and have you any ideas for improvement?
I suppose looking at each one of them individual groups, firstly starting with children, all people who present to the emergency department are assessed via a Manchester triage system, which is a clinical risk assessment tool. Children are automatically given a higher category within that system, so they're seen quicker. We also have a facility in the Southwest ED that they're seen and assessed in a separate paediatric area. So there's a national recommendation that children should be assessed and treated within a separate area than adults. So there's a separate waiting room and separate cubicles. Now currently, due to the staff and shortages, that's not operational, but we do have additional separate paediatric cubicles within the main department. Also for children, we have a good interface with our paediatric team. So they would regularly, as Joe was alluded to, come to the department to assess children. as and when needed and as and when referred. We currently also have safeguarding officers. This is the only trust in Northern Ireland that has safeguarding clerical officers working within the department who are doing live checks on any children that could be deemed to be vulnerable who present to the department. With regards to our mental health patients, I suppose this is one area which we have identified potentially needs improvement. Mental health patients are assessed using an assessment tool within the emergency department as well. We have good interface with our psychiatric colleagues, both in the TNF, but also now the psychiatric nurses are co-located on site within the SWA. The current service runs to 10:30 at night. So beyond 10:30 at night to 9 in the morning, we do rely on advice from doctors within the Omagh Hospital. I myself and have liaised with other managers, and we have identified a need for the development of this service. Our colleagues in Galvin have 24/7 service of this, so we are looking at getting that extended for ourselves. And the other area you mentioned was dementia and Alzheimer's. I suppose like any elderly patient that presents to the department, also like children, have a higher category, so they're seen and assessed quicker. We have, I suppose, a culture within the department to admit elderly people as soon as possible, because we know that this environment is not fully catered for their needs. So there is an emphasis on admitting them as soon as we can. I suppose, when we look at and highlighted nurse staffing shortages, our training is something that we are having a challenge with, and dementia training would be within that area. So that has been recognised, but we endeavour to meet our training requirements with regards to that.
Thank you very much. Thank you.
Okay, thank you. Paul.
Thank you very much. I think my questions are for you, Joe, if I may. I have the impression that the Western Trust takes seriously its PPI responsibilities. Those responsibilities, for instance, in the framework document, paragraph 5, which that paragraph places heavy PPI responsibilities on the Trust. And I also have the impression that the Western Trust takes seriously its equality and human rights responsibilities. And these responsibilities come from binding national laws, such as Section 25, and also binding international laws, such as the Disabilities Convention, Convention on the Rights of the Child. I could go on. And those aren't optional extras, those are binding international legal obligations. So then I ask myself, who funds this PPI work that falls upon your shoulders, and who funds this human rights and equality work that falls on the Trust's shoulders? So then I take a look at the Western Local Commissioning Plan 2013-14. Maybe I'm looking at the wrong document.
No.
But then I look at the
You're
Western
probably looking at the wrong person, though.
Well, I'll ask.
Teeing them up there here shortly.
I'll ask them later. And there I see the commissioning intentions are listed, but they include neither PPI nor equality and human rights. PPI is there at page 8, but outside the local, the LGC's commissioning intentions. Now, I think that those things, the PPI and equality and human rights, they're funded from core funding. That's what I learned earlier today. Supplemented by some very modest funding, £5,000 from the PHA. So first, am I correct?
You are correct, absolutely.
Okay, thank you.
Out of the £560 million that we spend every year in the delivery of health and social care, £560 million,
Yeah.
the vast majority of that comes from our main commissioner,
Yeah.
the Health and Social Care
Yeah.
Board.
Yeah.
There will, as Maura mentioned earlier, there will be opportunities during the course of the year to bid on a specific project basis for other small amounts of funding,
Right.
like, for example, from the PHA.
Right. So if the Trust went to the LCG and the Commissioning Board and said, look, we take this PPI stuff seriously, and we're required to under the framework document, and we take this human rights stuff and equality stuff seriously, we're required to. It's binding national and international law. And if they said that to the trust and said, we'd like some money to do it, please, right? If you said that, what response are you likely to get?
The Commissioner would say to us, we have no more money. And the Commissioner says that to us on a regular basis, and we understand that. No more additional money. I mean, the Western Trust is heading towards an overspend this year of £30 million.
Right.
We've had a letter from the Chief Executive of the Health and Social Care Board and the new Permanent Secretary, who's just been appointed, to remind all Chief Executives that they have no authority to overspend, and they've got to balance their books by the end of the year.
Right.
So they have asked for proposals about how we might turn down the spend. And we're saying, unless the Commissioner takes commissioning decisions and tells us what services not to provide, all the fat in the system has gone in previous rounds of comprehensive spending review savings. The low-hanging fruit, as it's referred to commonly, has gone, and we're down to the bone. So I know, and I'm not being funny about this in terms of, I'm sure Paul will confirm this when he speaks to you. The Commissioner is saying, unless we can find an opportunity within the existing spend to redirect existing resources, there's no new money in the system. And in fact, we're overheating on so many fronts. So what we've got to do then as a consequence, and this is what Dr. Maura O'Neill and colleagues were explaining, is that we've got to try as best we can to try and mainstream that activity as best we can in what we do on a daily basis. And it goes back to the point that you make, and you've heard this time and time again, about is it implicit or is it explicit? And in truth, the majority of it is implicit rather than explicit in terms of what we do. Because the resource we have, as you've heard from the Equality and Human Rights officers, is very, very small in the overall picture.
Yeah, it is very small.
Dedicated resource.
And it's core funding. So if I understand that correctly, so you sort of carve that out of the monies received from the commissioning board, although it's not separately itemised and commissioned and designated.
No, it's not.
But nonetheless, you sort of find it here and there, and it manages the show continues to keep on the road.
And primarily, it's a historical carving of it. You know, we've had a resource of 3 people since the trust was established in 2007. We haven't added to it, but we haven't taken anything away from it either. But it is part of the core funding.
Yeah. I mean, speaking for myself, I'm really troubled by this. Here we have binding obligations, and it's not your fault, Joe. You know, and you're not being given money to action them. I mean, I find it very, very strange. Anyhow, third and last question. In your long experience, how much scope does your trust have to go beyond the ministerial priorities? And what I have in mind is that in the local commissioning plan for your trust, just as by way of illustration, you're probably completely familiar with all this, but nonetheless, if I may, there's a ministerial priority, which I completely understand, and it says, quote, by March 2014, secure a 10% reduction in the number of emergency readmissions within 30 days, okay, ministerial priority. And then in the other column, which I think is the sort of LCG action column, it says, and I quote, the LCG work collaboratively with ICPs and Western Trusts to ensure plans are in place to reduce emergency readmissions within 30 days are reduced by 10% by March 2014. So it's really just using the language from the ministerial priority. Nothing wrong with that.
Yeah.
But my question is, in reality, how much scope does your trust have to go beyond the ministerial priorities? Do you see what I mean?
In truth, very little. Very little. Okay. Because most of our services are governed by what's called service and budget agreements.
Yeah.
So, for example, we have a service and budget agreement that will say the Commissioner is funding the Western Trust to have a complement of no more than 400 looked after children. We currently have 523 on our books. That means that the additional funding associated with those additional 123 is not in the core funding. And it's part of our overspend, it's part of our discussion with the Commissioner to say, what do you want us to do in relation to this? So in reality, we don't have a lot of scope.
Okay. Thanks, Joe. I've got other questions, but we're 20 minutes over. We have some important people sitting there, so I won't say any more. I'll pass back to the Chair.
Joe, thank you. That's been really helpful from all three of you. We would be happy if you want to augment anything you've said today in writing, but there are two things I think we would find particularly helpful. I think a bit more detail for us about the telephone arrangements with GPs and the GP relationship, and if you have a service level agreement or any documents about that, that would be particularly helpful, because I think we would find that useful. And also around the protocol with the ambulance service and the idea of being on call for the ambulance service, in your case, Campbell, and kind of how that works in practice. And again, anything you have in by way of service level agreements or documents would be really useful, because we're looking at the advantages of sort of good practice that might be rolled out elsewhere. So those two things in particular would be very helpful. And finally, and even though we are 20 minutes late, is there anything you want to finally say to us that you think you've not covered this afternoon?
I think we've covered.
Okay, look, thank you very much. That's been really helpful.